Good afternoon. Welcome to the mmlearn.org. Our presentation today is on falls. I'm so delighted you are here to join us. Let's talk about falls. Where do falls occur? And I want you to know for sure that this presentation is usually directed to those that are in assisted living, skilled nursing, some independent living. But today this is a program that is directed at every one of us because falls happen in the home, in the community, all of our facilities, hospitals. There's just no place even out on the sidewalks in front of our homes. So every one of us is affected by this, and not just by age. What I do want you to think about, though, that falls are the leading cause of fatal and non-fatal injuries of older adults in the United States. And by the time that I finish this program today, 2 people will have died in our country from a fall. And I think those statistics are just amazing. And we're going to hear more about that as we go through the program. There is so much information on falls, and when we talk about best practices, evidence-based learning, there are so many places to go. But I want to take you through a few of them. Some of our information today came from AMDA. That's the American Medical Directors Association. The Center for Disease Control is actually doing a tremendous amount of research and gaining lots of information and statistics on falls, and put out some wonderful brochures and information on preventing, treatment, all sorts of things that will help you no matter where you are, no matter where you live. I also want to talk about the Texas Department of Aging and Disability Services and the quality monitors. They have some extraordinary information, and I took a lot from that. And this is what that page looks like. And at the bottom, you can also see there's the link to go directly to this page. There is an item on there that deals just demonstrably with falls. But what I want you mostly to think about is what this includes. And this managing fall risks was developed for skilled nursing facilities, but I want you to know it is just as pertinent for assisted living and a lot of home care issues to look at. So it'll give you a good overview. It talks about resident evaluations, care planning, quality improvement, which I think was very well written here, some related technologies. But most importantly for you, those of you who are getting ready for survey or have other concerns, is to look at the related tags. They have 3 pages of F tags that are associated with falls alone. So if you have any questions, this is a great website to go to. And it gives you lots of additional resources where you can get information. So we're going to get interesting with this, get more interested, but I do want to direct you to the site because I think it's very important. And we have such limited time to talk about such a tough subject. So please go back and look at this and take a look at that quality monitor. So I'm going to ask Nina about every 10 minutes or so to give me an update with questions. But again, if you will just let me know how many people are online, if you're watching us, and tell me a little bit about what you're doing. And I'll share that with you as I get it too. So we have Bertha, who's there alone. We have Dayon, who's at the Meadow. And 10 people have joined us at the Meadows. I thank you for being with us and look forward and hope this information is helpful to you. Let's talk about allegations of abuse and neglect. They always scare us. Any time that we hear the words abuse, neglect, we feel not us. But the truth is, in regards to falls, sometimes we are neglectful in caring for residents and not doing everything that we can. We think about this in regards to legal action usually. Legal action means money, loss of money. I think this is important. We can't ignore this, especially when we get to documentation. But it's not the most important reasons that we're giving this lecture on falls. I do want you to know, though, that in 2009, resident falls were 44% of claims that were done by allegation. Death in 2009 accounted for 41% of all the closed claims. That means they were settled or went to court. 41% of the claims, that's almost half, were due to falls, and that death due to falls. And fractures were 26%. So I think these are really amazing statistics when it comes to legality, and we need to be very, very careful about this. And I'm going to talk more as we go through. Resident outcomes out after falls is just appalling. that if somebody falls and is hospitalized, they'll usually stay double the time of any other stay. Any other stay, their hospital duration lasts twice as long. And even more startling is that only half of those people from a nursing home will be alive 1 year later after a fall. So this tells you that as someone's aging up, their likelihood of survival goes down with each fall, and we know that many people have more than one. Resident outcomes after falls. And let's see here. Some other folks joining us, and this is fun. From the Manor, we have 5 people watching. No food. Manor, ooh, I'd call pizza in. And oh my gosh, and Chandler is here, and they're waiting for a few more to show up, so that's wonderful. Keep them coming in from wherever you're at. Resident outcomes after fall. I want you to know that between 10 and 25% of the persons who have fallen admit that they avoid activities because of their fear of additional falls and injuries. This becomes something that we're going to follow as we go through this program today because it's so pervasive. But fear of falling is one of the greatest reasons for falls. And look at how this isolates people and makes them stay in that fear is so great. We're going to talk a little bit more about that. Evidence suggests that falls may precipitate symptoms of anxiety and depression. And this is kind of like the chicken or the egg, which comes first. But we sometimes talk about falls happening because of anxiety and depression, but it may be the other way around. So these are all comorbidities or other issues that we need to be very aware of, that what happens once somebody does have a fall. But what I don't want us to ever forget about, we can talk about legal issues, we can talk about F-tags, we can talk about all these things, but I want you to know what we're really talking about is the resident and what happens when somebody falls. It is the bruising, yes. It is the pain, yes. It is the fear. I can tell you I've been more careful all day since my fall yesterday. Isolation, I am not isolated, but you'd think so since I'm in the room alone. And embarrassment. And this is very interesting because when residents talk about their falls, they want to minimize them. They don't want to talk about the fall because it is embarrassing. And for any of us that have fallen, you know how you try to get up right away because you don't want anybody to see that you did that. So these are all things to remember as we go through falls. It's all about the resident. So I'm going to ask you, where do you think might be the number one, or what do you think might be the number one cause of all falls? And I know many of you are in a room together, so just share what you think might be the number one cause of all falls. Well, it's muscular weakness, and especially in the lower extremities. That is cited in almost all literature as that number one reason. What we know, and we continue to train and train and train, are risks for falling. But look at the top is that muscular weakness, some gait and balance problems and disorders, dizziness or vertigo, the inner ear problems, confusion, incontinence, stroke, Parkinson's disease, vision and hearing impairment, seizures, depression, and previous falls. If somebody's had a previous fall, the likelihood is much greater that they will fall again. Gosh, I hope not. Let's look at what we need to do. And so, since muscle weakness is the number one reason for falling, I think it's important to spend a little bit of time on this. The first question we ought to ask is the person getting physical therapy so that those lower muscles are not so weak? And are we effectively using physical therapy, both inpatient and outpatient? Are we fully using our restorative aids if we're in a skilled nursing facility? Or are we asking them to do a million other things instead of their programs for restorative? Those of you who work in skilled nursing know how common that is. Do our activities promote balance and strength programs? And I want to say I never want to criticize activities because I think they have one of the best and hardest jobs that we have as well. But I do want to talk to you about some of the exercise programs that we have. Are they evidence-based? Are they really making a difference? And we're going to talk about some of these exercise programs in a few minutes, and I'm going to show you some tapes that are available to you for free that you can order. But I want to make sure that those balanced programs that we're doing are evidence-based and really are creating increased strength in lower extremities. Doesn't mean somebody has to even be able to stand. After every single fall, do you consult the physical therapy department or do you get hold of PT or have a physician evaluation to see if that person would benefit from physical therapy? Another question that I always like to ask is, are we creating muscle weakness ourselves, lower muscle weakness? And you might ask me, well, what does that mean? How could we do that? Instead of taking the time to walk slowly with someone from their room to the dining room, do we wheel them in a wheelchair? Because it's faster and it's easier for us. Do we take the time to walk somebody every time that we possibly can, or are we too much of a hurry? Because in the end, if we are part of the problem of creating this muscle weakness, I think we need to look at that in our care planning and what we're doing. And this is just as much for those people at home that have someone that it's easier to put your loved one in a wheelchair than it is to stop and take the time to let them do a little bit more walking. Vertigo and dizziness is another major issue. And we have to teach the resident and aides about allowing residents to move from one position to another slowly. Reminding people when they're getting up, sit up slowly. Let your legs dangle off of the edge of the bed. When we get somebody up for the toilet or even up from the toilet to move, to do it slowly. Let's talk about orthostatic hypotension here. This is a drop in blood pressure when somebody changes position. I often wonder if we do orthostatic blood pressures when we do a first admission, or do we just not think about that? And I think this is really important when we're talking about fall risks. And before we even get to risk assessments, we have to talk about what happens when somebody's blood pressure drops when they go from a sitting or a lying position to standing. And we can measure that with a simple blood pressure cuff. And we should allow somebody to lay down, and I did a little bit of study, so there's different ideas on when and how frequently to do this, but just think about this as a good rule of thumb. And in Lippincott Manual of Nursing, this is how they tell us to do it. Have somebody lay down in a supine position for at least 3 minutes and relax and take their blood pressure. And then you can sit them up if they can't stand, or preferably standing, for 3 minutes and repeat the blood pressure. And this is what they say, that if you have orthostatic hypotension exists, if the systolic blood pressure, that's the top number, drops by 20 milligrams of mercury, so that's 20 points, or the diastolic blood pressure, the bottom number, drops by 10 millimeters of mercury, or 10 points. There can also be changes in the pulse from laying and to standing. And people are not always as cognizant of this. So if you don't have a blood pressure cuff, sometimes if you take a pulse when somebody stands and the pulse goes over 100 and it was way below that before, this can be a sign of volume depletion. And that means that somebody might be dehydrated, somebody might have some internal bleeding. If they've had a fall, that's a real important thing to do, is to get that pulse rate, if you can, laying down and then sitting or standing and seeing if you see a difference. I think this is very important that we look at all of these aspects, and I know this sounds very nursing for those of you that aren't in a nursing environment, but you too can get a blood pressure cuff and do this testing. So let's just check in with you for a second. And 214 Martin, oh my goodness, down in Uvalde, thank you for joining us. We always love having you with us. Oh my gosh, they have 11 present, and they want to know what the other guy looks like that I got in the fight with. That is not funny. Diane is watching from Ipswich. We're delighted to have somebody. Is that in Massachusetts? And Let's see, what over-the-counter medications mixed with prescriptions cause falls? And I'm going to get back to that question, and that's a great one, because our next topic that we're going to have is to have a geriatric pharmacy with us, a pharmacy consultant. So that's a great question. It is true that medications are some of the #1 reasons for falls, and that you will see postural hypotension with, which takes us back to taking those orthostatics. And diuretics. Diuretics are one of the #1 folks, and that causes frequent urination, and that can cause dizziness, some of your blood pressure medications. But I'm excited that you're asking questions about meds, because that's our very next topic. Vision and hearing impairments. Well, I think that this is really simple when we talk about good lighting. And everybody knows that we need more lighting as we age. Our eyes don't adapt as well to low lighting. But isn't it interesting when we go into facilities or even in our own homes how we let the lighting drop? At night, we'll turn down the lights. We don't think about using night lights. I'm always amazed when I walk through nursing homes at night how dark some of them are. Instead of turning up the lights so that when people get out of bed or having a light on in the bathroom, we're turning those off. This is the antithesis of what we should be doing. Glasses and hearing aids, huge. Previous falls, we know that previous falls account for fear of falling, and they may lead to more falls. And how do we build confidence? Do any of you have ideas on what you can do to build confidence? I'd like you to send those in to me if you would. And before the end, we'll talk about those for a minute. But some ideas are just with exercise, letting people know that they've done everything to secure their home or their room, working with a physical therapist. Give me some of your ideas of how we build confidence to prevent falls. Incontinence. Why does this lead to falls? This takes us back to medication. One that we said was the diuretic. If somebody is on a diuretic, they're going to have urgency, a need to urinate more. And so they may rush to get to the toilet. And if they don't make it in time, just because they're rushing, that might be one reason. Another reason is sometimes they lose continence, and they might void on the floor, and they will slip in their own urine trying to get to the toilet. It's very interesting, and I'm going to talk a little bit more about assistive devices later in the program. But one of the things, I was just in Chicago at a conference, and they were talking about with assistive devices like a walker, most of the falls that happen, they find that people who use assistive devices did not use it during the night or in their bedrooms when they went to go to the bathroom or when they got up to get a tissue or something else. So we'll talk about assistive devices again later, but I want you to think about why incontinence leads to falls. And we need to be training this to all of our CNAs, any home caregiver, and family members, and even ourselves if we're taking a diuretic and we're rushing, because most of us don't have carpeted floors in a bathroom, and this is a real opportunity for slipping. Those were intrinsic or internal reasons for falling, but what are some of the extrinsic, those exit outside of ourselves? Our lack of handrails. This doesn't mean just in a nursing home. These are handrails going up and down stairs. These are things that can be attached. These are going in and out of a house. Again, we look at poor lighting. What can we do to improve the lighting in a home? Independent living, just as important. If people are out walking around at night or out in the hallways, we need to have adequate lighting. Wet floors, of course. Loose rugs. Footwear we'll talk about. Alcohol. And this alcohol we're talking about is the type that we consume, leads to more falls. And assistive devices, and we'll spend a lot of time on that. Medications, and you're asking about some of this, are antipsychotics, sedatives and hypnotics, antidepressants, the antihypertensive, and we just talked about diuretics. Most of all, if there's one single reason that we know that we have falls, it's the use of 5 or more meds. When people were asking me about over-the-counter meds in the previous question, let me give you a point here. 5 or more meds is not limited to whether they're just prescriptive meds. 5 or more meds can be over-the-counter medications as well. And what would one of those be that can cause falls? Well, Benadryl. That happens to be a drug that's on the Beers list, something that shouldn't be given to older folks, but do you know that Tylenol PM is the same as acetaminophen with Benadryl? That's exactly what it is, or diphenhydramine hydrochloride. So I would say to you that we have to always look at medications. If you are a family member at home, you should be looking at every med you're taking. Discuss that with your physician and your pharmacist. Can that be causing falls? If you're in a nursing home, the pharmacy consultant should be looking at that. But nurses, we are responsible to be looking at every time somebody falls, doing a review of the medications to see if that could have been contributing, and looking at them before we even start to administer them. When we change meds, letting our CNAs know that we have new medications. So, any questions? Looks like we do have some questions. That's great. Okay. Okay, the manner gave me some ideas for building confidence after a fall. Strength training, absolutely. And that can be through activities, restorative, PT, having more attention paid to them for the next few shifts, absolutely. Because they're so scared of falling that just knowing that someone else is watching out for them helps. And extra transfer training and practicing. And that's something that comes up later in our program. So I think you're hitting them right on the head. And I want to know from you others who are watching this, what are other things that we can do to build confidence after a fall? So I think we've covered those extrinsic reasons for falls. I want to ask you this. We do so much training on falls. We hear about it so much that I think we almost get to the point, because we see so many falls, is there anything we really can do to prevent them? And the answer is unequivocally yes. We can do things to prevent falls. For those who are in skilled nursing facilities or assisted living facilities or in home care with a home care agency, and our frontline staff have assignment sheets, I want to tell you the thing that worries me the most is when I see fall risk. What does that mean? This person is at risk for falling, so what am I supposed to do? We have to give our frontline caregivers much more information than the two words fall risk, that this person is at risk for falling. We have to know, why is that person at risk? Is it their medications? If it's sleeping meds, did you know that you are 2/3 more likely to have a fall than anyone else if you're taking a sleeping medication? That's something right there that an aide should know, or a frontline care worker should know, that somebody is on a sleeping medication. Are they on diuretics? Because they will have urgency. They will rush to get to the bathroom. What are we doing? Previous falls. We know that they're scared. And that in and of itself makes somebody tentative. They might have weakness in their extremities. We talked about that. They need more assistance with transferring. If they have dementia, do we need to know that on the assignment sheet? Absolutely. Why? Because that person isn't going to use a call light. That person isn't going to ask for help. That person is not going to stand up slowly. That person is not going to use their assisted devices if they have severe cognitive problems. So you have to look at, why would this person be a fall risk, not just a fall risk. What medical conditions do they have? Does this person have incontinence, diabetes? Did you know diabetes makes you more at risk for falls? Inner ear dysfunction. We talked about equilibrium. All sorts of Parkinsonian disorder. All of these things, we have to know the reason why somebody might fall. What else can we do? Can we prevent these? Well, even a low bed won't prevent a fall. But I can tell you that a low bed has the opportunity of reducing the impact of that fall, and especially if we put a mat by it. And we have to look at, can we do anything to prevent falls? Back to the question, can we? Yes, we can. But we have to think through it and not just assume there isn't anything we can do or just call somebody a fall risk. Let's talk for a second about exercise. I can't tell you the number of programs that I went to when I was recently at a conference, another program that I was at down in Laredo just last week, and all the reading that I did for this programs and others like it is, what kind of exercise are we doing? I thought it was fascinating, but at a program that has been done in Oregon, and these tapes are free from them. If you write me, I'll send you the information for it. But it's called Tai Chi, Moving for Better Balance. And not just for folks who can stand. They even have Tai Chi for people who cannot stand that do this in a wheelchair or on a chair. There are programs called It's a Matter of Balance. Some called Stepping Out. Some called Stepping Up. Another one that I just was sent was called Safe Steps. These are all programs that have evidence base behind them as being effective in increasing muscular strength, core balance, and helping to improve people's confidence to reduce falling. And this isn't even physical therapy. This is something we should be doing with our activities, whether we're in independent living, if you're living out in the out in the community. What is the exercise that you're doing to improve your balance? And I think I'm signing up for Tai Chi. Okay. Pets. I would never discourage anyone to have a pet because of a fear of falling. I think pets are, we've all watched this in our facilities, in our own home. I have 2 dogs, but I happen to love this picture, and we have Michael who's doing some work with us now here at the Training Institute, and he found this picture with this woman walking on the cobblestones with her dog, and just looking at that uneven sidewalk makes me uneasy today. But I want you to know that pets are something that we really have to work with folks. The pets may need more training to be with them, and we need to look especially at people who use assistive devices and have pets, because I see them tied to the walkers, having a cane and holding the dog and lifting up the cane. We need to be very careful and do a lot of training with folks with animals. In our facilities where we have pets, I think it's wonderful, but also we need to make sure that they're safe pets. They're the right size and that they move around the residence, not the other way around. No bigger issue than footwear. I have to tell you that when we look, and we'll get to incident reports in a few minutes, but I want to show you this shoe that has Velcro and tied shoes. There is a whole program. I think I could spend an hour after doing this research on what type of footwear you should be wearing. But I would say to you that one of the things that I learned was you cannot have a real thick sole, and the shoes should not be too heavy. And many times I walk through and I'm looking at folks in some of our facilities wearing Crocs, open sandals. We really have to be careful and encourage families, our residents, to have appropriate footwear. And we may even have to talk to somebody in podiatry about the appropriate footwear and orthotics. But they do suggest a thinner sole, even, lighter, and that the shoe be able to tie. And the reason for that, and of course you have to be careful with laces, but the reason is because as the foot swells and gets smaller, that you can adjust the tension on the shoe. I'm sure there's some that can be done with Velcro like that, but they still recommend the tie shoe. And then if you are going to use slipper socks, do they have a traction on them? We all know to look for footwear, but I'm always amazed, and I'm getting ready to take a camera out and just walk facilities and take pictures of what people have on their feet. So kind of be my eyes and ears for some of these things and let me know what you're seeing in regards to footwear and residents. Cords, rugs, and clutter. I mean, this is just basic 1, 2, and 3, but let me give you the one that we don't always think about are the cords that are attached to chairs and to monitors that are alarms for people to prevent falling. We know they don't prevent falling. We know they just alert us to someone standing up. 2 issues here when it comes to bed and chair alarms. One is they can get caught in the cord if it's not a cordless system in a bed. And we've seen that before, and I read some of the cases involved with that. The other issue is here with the cords and alarms is many times what we say to people is you need to sit down, instead of using this as an opportunity when the person is trying to get up to help them to walk, again, to improve their muscle strength and to get them to the toilet or to see what their other needs are. And that's all part of preventing falls. So let's take a second again and remind you that in the upper left-hand corner, you have a little bubble that you can click and send me a question if you have anything about what we're talking about, or even just send me some ideas for topics you'd like to see in the future. You can also call us at 210-264-7000. There's somebody on the phone to take your calls, and they can give those to me just as easily as this. We want you to feel part of the program here as we talk, because we sure feel like you're here with us. How many of you are wearing glasses? And I'm going to look at my glasses real quick, and they are not good. They are not. Do you keep them clean? Because gosh knows I didn't do a good job here. I'd be embarrassed to show these to you right now. We have a responsibility with residents that are in our facilities to clean glasses. And I can't tell you how many times I walk through the facility and see glasses that look just like this. And we wonder why somebody's falling so much if they can't see out of their glasses. I mean, we know that that's just common sense for us, but we don't always think about that for our residents. What are we cleaning them with? Are we doing a good job? The other issue is, are we really thinking about those residents that can still benefit and are still capable of participating in a vision test and going to an ophthalmologist or an optician to find out what we can do to improve their eyesight? We do know that just like we have to change our glasses all the time, because somebody moves into a nursing facility or assisted living doesn't mean that they don't have to have this care any longer. They do. Okay, I think this is one of my favorite topics to talk about in regards to fall, and that is assisted devices. And the question is, do assisted devices help prevent falls? And the answer is not always. Because if the person doesn't use the assistive device all the time, it doesn't work, it won't prevent a fall. Just like we talked about, if people are not leaving the assisted devices near or within reach of a person by their bed when they're going to get up at night, or will they get up and fall over the assistive device? Is the device properly fitted? And how do we know it's properly fitted? If somebody moves into our facility with an assistive device, it seems like everybody comes in with a walker or gets one, and I'll show you a picture in a few minutes, once they're in a facility. Were they fitted for the cane? Was the cane something that was suggested to them? Do they actually know how to use it? When it comes to a walker, is it the appropriate walker for them? Some of the walkers have the little slides on the bottom that go right underneath carpets that can cause people to fall. Sometimes we see the tennis balls for traction. Have you ever looked and lifted them up to see that there is no more traction on those tennis balls, that they need to be changed? Has the individual been instructed how to use the assistive device properly? Is it accessible to the person? And is it possible that the device is causing the fall rather than preventing the fall? And a study that they've done, and it was really fascinating, and I got to listen to this in Chicago. It was an hour and 45-minute presentation, and they're even doing some work with robotics with assistive devices. But they really feel like people may not be using these enough. And while I can see I'm running okay on time, I'm just going to tell you real quickly that they did a test of putting a pedometer on a person's foot and on their cane to see how quickly they matched. And they didn't match at all. The person wasn't even using the cane. And I walk through our facilities and sometimes see people waving the cane as they're walking and calling to someone else with the cane. So these are all things to think about. This is a real question for me with assisted devices, and this is taken in a facility outside of a dining room, and these are all the walkers that are lined up for valet parking. And I wonder how many of these residents came into our facility using these walkers when they came versus how many do this almost like a status symbol, because if everybody else has a walker, do I need a walker? Dependency on assisted devices when you don't need one may be more disadvantageous than it is advantageous. So I want us to think about that, because this really is a picture that just paints 1,000 words. Now let's talk about after the fall. First of all, you know that you have to evaluate and assess the resident for injury. And you have to take immediate, appropriate intervention. And in these medical emergencies, of course, there are going to be those times that you need to call 911. If there's no injury, we know that there is continued observation that's needed. But let me tell you something that I find very concerning, and that is sometimes we will observe people for 24 to 72 hours after a fall. If that's it, even an unwitnessed fall, the observation period is over and it drops off. I want you to know how often we see cases of people who have fractures weeks later that were not picked up, but more importantly are the ones who had subdural hematomas that we didn't realize they had such a slow bleed. And if you all can remember back, and any of you who's joining me, with Ronald Reagan, had that happen to him after an accident. He was great for weeks and all of a sudden developed a subdural hematoma. You know that after every fall, not just falls in a day, but every fall you have to report the fall to the physician, the family, and you have to have a means of notifying other people on the staff about the fall. Because if I'm an aide on the morning or a nurse on the morning, I have to know in the afternoon and the night what happened in regards to the fall and why did the fall occur if at all possible. Please don't forget the orthostatic blood pressure monitoring. If you have any questions about that or how to do it, feel comfortable calling me. I'll be delighted to talk with you about it. We're so limited in time, 1 hour, probably 45 minutes to be able to answer all the questions, but most people want to know what to do after a fall. We have a whole class on this called Common Geriatric Emergency. Falls are completed throughout that entire course. I encourage you to take this program if you get an opportunity to, but in talking about falls, I just don't have enough time to go into the interventions for this, but I think this will be real helpful to you if you feel that you need more information on what to do once a fall occurs in regards to the medical interventions. Post-fall counseling, of course, involves physical therapy to evaluate. The nursing care plan should be updated, but let me say this, folks. Nursing care plans don't mean anything if they're in the back of a chart and nobody has access to them and nobody reads them. Nursing care plans are so important to advise us what we're doing, what kind of changes we're making. If this change doesn't work, what change will? But if it's in the back of a chart behind the nurse's station and the people who need to read it the most can't get hold of it, it has no value. But the nursing care plan needs to be updated with each fall. A pharmacy consultant review is very important. And if your pharmacy consultant doesn't know about a lot of falls going on with your resident, there isn't anything they're going to advise you on because in a lot of cases they may not pick up and read all those notes. If you're in an assisted living, you may not have a pharmacy consultant. And what can you do in that case? You can call into the pharmacy that's supplying the medications and review them with them. If you're a family member at home or you're a resident living in one of our assisted living facilities or independent living facilities, you have the right to take all your medications in a bag to your pharmacist and have them look at them, or your doctor. And I encourage you to do that. CVS, and I'm not promoting CVS, but they have a brown bag program that encourages you to put all your meds in a brown bag and bring it in, and they'll review them with you. And then, of course, with risk management and quality assurance following up, we may get different ideas that we can go back and do post-fall counseling. Some people are so traumatized they need to work with a social worker or a psychologist. So let's take just a brief break here and look at here. From Ms. Brown, exercise program information. She'd love to get some information. Thank you, and I will send that to you. And if you have anybody else has questions about those programs, I'm delighted at. Can you talk a bit about spontaneous fracture secondary to osteoporosis? Are there any statistics on the number of falls due to that? Any preventative measures other than diet or meds? And also, what are the correct procedures to follow by non-nursing personnel after a fall occurs? Okay, let me start with the easiest one first. The appropriate procedure for non-nursing personnel after a fall is they're not a nurse, they're not capable of doing an assessment, and it is to call 911 and allow them to do the assessment. It is embarrassing to fall. I was embarrassed yesterday to fall. But I want to tell you that if there was any concern on my part that I could have really hurt myself, I would not have gotten up. I would have waited for someone to come. I'd probably still be laying there. But anyway, I want you to know that there are opportunities to really hurt yourself by not being assessed. You can even have a broken bone that can sever an artery getting up. So I never expect anybody who's non-nursing to do a post-fall assessment. Spontaneous fractures and secondary to osteoporosis, I have to tell you that I don't feel that I am versed enough to answer that question, but we have Ask a Geriatrician coming in. I'm going to save this question. I'm going to ask Dayon to get whoever asked that question to be there, and we're going to ask the geriatrician to talk about what is the current finding with spontaneous fractures. I know there's a lot of questions right now about Fosamax, the use of vitamin D, and I think those are important questions, but I have to tell you, being not a physician, I'm not comfortable answering those, but I promise you we'll get you the answer. So ask a geriatrician, or I'll ask one for you before they even come. Incident reports are not just about regulators or lawyers. These are not about people coming in from the state or physicians. Incident reports tell us a lot. They tell us where most falls occur. Where do you think they mostly occur? And in a minute, I'm going to ask you about your different facilities. Is it on one hallway more than another hallway? Why? Is it because we have equipment out in the hallway? Is it because we don't lock the equipment and somebody's pushing up against it? Can we identify there's a single caregiver that has more falls occur on his or her shift or with their assignments? Are we using restraints? Was the assignment sheet up to date, or did it just say fall risk? Are there adequate lifting devices, and are they safe, and are the slings good? And do we lock them when they're out in the hallways? What shift, what time, where did these incidents occur help us to answer questions? And if we just put incident reports in a file, they're not going to tell us anything. Do incident reports match documentation? Oh my gosh, this was one that just drove me insane. To go read the nurse's notes and then look at the incident report, and I wouldn't even know to put them together. They don't even say the same thing at all. All information that is on the incident report that is reported in the medical record should be consistent. There shouldn't be any differences. Incident reports should never be addressed in a medical record. You don't say, see incident report or incident report completed. An incident report is an internal document for quality assurance. It is not part of the medical record. And so surely don't file it in the medical record, but it should not even be referred to. But documentation for a fall should be complete, and it should be meaningful. It should be able to tell us something. Where, when, why, was it witnessed, unwitnessed, injury, no injury, anything at all. And remember this, that taking a resident's statement about the fall is all right, but I want you to know that we have learned in most cases it's not accurate. When they tell you that I fell when I was trying to do this or that, if they hit their head, they may not even remember what happened, but they're embarrassed, and you will hear so many people try to cover why they fell. You do want to take down the information, but you need to make sure that you're doing a further investigation. Quality improvement, quality assurance, it's more than completing a report. It's what are we going to do and plan for interventions. It's very interesting that when you read the research on this, they tell you to only do one intervention at a time. And as I looked at this, I don't know how you would do that and be fair to the resident. But we can talk about that. You can even call me and ask questions. I just wish this was a 2-hour program for all I've learned about falls. Risk assessment tools. And I want to state this to you, that according to the DADS Quality Monitor website, they say there is no well-validated assessment tool for identifying residents that have a high risk for falls. That doesn't mean that you don't do a risk assessment, but it is true that we don't have a single well-validated assessment tool. And in all the programs I've attended and read, there are many different tools. The most important thing is, are you completing it? Are you doing it? Are you using it for something? And are you conveying that information to your staff? For risk assessment tools that are not dealing with nursing home, I want to tell you there's some fabulous risk assessment tools. One of them, and lots of these information tools, and we'll get to them in a minute, are things that you can do yourself at home to look at risk assessments, or in independent living or in an assisted living, how to look at your own space and what is going on in your life to prevent falls. When should assessments occur? on admission, they say within 24 hours, I say on the first shift that somebody's there, because if there's something outstanding that you know puts a person at risk for fall, everybody on the staff needs to know that. Every quarter, a risk assessment should be done for falls. Another one is with any significant change of condition, because we know when people get pneumonia, UTIs, weakness, lethargy, confusion, all of those things can lead to a fall risk. But most important, it's a significant change of condition, and every time there's a fall, we should do an assessment. People have asked me, do we repeat the fall risk assessment if somebody falls 3 times in a day? First of all, 3 falls in a day is pretty serious, and the doctor must be notified with each fall, as must the family member. And I can tell you that you should see if there is any difference in the falls. An incident report is made with each fall. So if there's 3, the risk assessment, unless it changes with the fall, you would not complete 3 risk assessments unless there was something different within the fall. But please do not forget that you have to let the physician and the family know with every single fall throughout the day. All right, so as we said, assessments are not just for nursing facilities. Home assessment tools are readily available online from lots of sources: AARP, CDC, the National Safety Council, NCOA, ASA, and you can see that we have these programs here, but also up in the corner of your program is a little, it looks like a paper clip, and if you click on that, there are links to all of these sites where you can do home assessment. If you live in independent living, you live out in the community, in your own home, folks, you should be looking for those things. And there are a lot of things in these brochures that I hadn't even thought about that put us at risk for falls. It's just not scatter rugs and bathtub floors or the inside of a bathtub or step stools. There are so many things to think about that I really encourage you for your safety to do this. I can't stress enough training, training, training. And if it's staff, it's not just nursing. It has to be our activities, our dietary. Everybody that works for us needs to have this training. We need to know, and this goes back to the manner saying, what can we do? Transferring residents safely. We must teach people how to transfer folks that we're using mechanical lifts. If we're using a single-person transfer, a pivot transfer, what are we doing? And does our staff feel confident? Because our residents can't feel confident unless our staff feels confident. Do we need to make a modification of the room? Do we have too much stuff in the room? Are the cords in the room? Are there rugs in the room that make it very hard for a wheelchair or for a walker to go over? Do we have the right kind of base on the walker? The risk hazards and medications, training, training, training. Our CNAs need to know the meds that our residents are on if it puts them at a risk. And let's just go back. If we only talked about 2 or 3, it would be sleeping meds, diuretics, and antihypertensive. There's tons more. But if we could just explain some of this to some of our employees or folks that help us, I think this would be so important. Activities should be just integral in our interdisciplinary team to preventing falls, and especially with our activities that deal with strength building, and it should be fun. This doesn't have to be work like the rest of us going to the gym. There are so many great things out there. Should we train families? Unequivocally. Every family member, whether they're within our facilities or out in the community, should be trained about falls. There is so much they can do to help with reminding, and if nothing else, understanding what we're doing to prevent those falls, how concerned we are, and what our plan is. And when something doesn't work, letting them know with the fall what we're going to try next. It is a matter of concern and commitment to reducing these. Can we reduce falls? Yes. Can we eliminate them altogether? No. So it's training for residents or patients if it's in a hospital or another, or just individuals of what they can do. So I'm going to take the course when I finish. So I'm going to ask you some questions and we're going to end on these, but let me see if you all have one for me before. Okay, let's see here. I would love the information, okay, on the Tai Chi tapes, and I will make sure that we get that off to you. So if others of you want it, please just send us your email and name and what you would like to have, and we'll make sure that you get that. So let me ask you these questions and run through them. If I were to ask you, what are the top 3 events associated with falls in your facility, could you tell me? If you have a quality assurance department, you're filling out incident reports, or you're even in independent living, and you have falls that are going on, can you tell me right off the top of your head, what are the 3 events that are associated with falls where you work? I hope you can answer that question. And if not, you should be working with your incident reports and your QA team to do that. Where do most of your falls occur? This isn't the event that's associated, but where do they occur? How do you know that staff are performing resident rounds every 1 to 2 hours? Well, we know that people make the rounds to turn folks every 2 hours in skilled nursing. But if we're not making rounds to see that people have water near them, they have assistive devices near them, that we've gotten people up to toilets so that they won't get up in a hurry to do it themselves, how do we know they're doing those rounds? Do you have nursing staff that's watching? Are they involved in the rounds? How do we know? Do your rounds address this? Positioning, toileting, placement of the call light, water, tissue, glasses, and assistive devices? Do they? More questions. Does your staff receive the appropriate training regarding falls? I don't think we can do enough training for this, but this in and of itself today is a start that you're with us and you're interested in this, and we really appreciate that. Can your nurses and medication aides identify which medications are likely to increase a resident's risk of falling? Can we just talk about 1 a week? Can we continue to train? Can we have a list? Can we put them on the assignment sheets to let people know what they're looking for? Are you looking at the resident's visual acuity as it relates to falls? Basically, are you cleaning their glasses? Are you getting them an eye exam? Is your resident service plan or care plan really addressing falls, and who sees it? Goes back to my same question. Who sees the care plans? And if they're not getting the care plans, is it on the assignment sheet, all the information they need to know? Even more questions. Are interventions discussed with the family? It's really important that the family knows what we're doing. This is a team effort. And if they're coming in and bringing socks and not the appropriate shoes and trading out shoes that you weren't aware they brought in, so we got to keep them involved. Do your service plans specify when 2 employees are required for transfer or when mechanical lifts are supposed to be used? Are you looking at the slings? Are you having the mechanical lifts serviced? Are you staying on top of all those things? These are the things that help us answer, yes, we can help reduce the number of falls. Do your staffing levels allow assistants to remain with residents in the bathroom if it's required? Is it on the care plan that they should stay in the bathroom with the resident? This is always a problem. I mean, I'm a realist. For any facility, wherever you work, we never feel like we have enough staffing. But have we identified those residents that we better stay with? So, do you utilize low beds? Do you have hip protectors and helmets? And if you do use a helmet for somebody, have you weighed the dignity, what the family wants, the resident wants against their safety? This involves ethics, too. Implement interventions to prevent residents from sliding out of chairs. How many incident reports do you all see that say residents slid out of the chair? Do you look at all the assistive devices for safety? Have your mechanical lifts and slings, again, been evaluated? I just want to end and tell you we cannot prevent all falls, but we have to try to prevent as many as possible. I do believe we can make a difference. The more that I study this, the more I'm committed to this. Just think about this. 2 people have died while we've been in this program today because of a fall. There are people that will stay double the time in a hospital. This is just profound. So for evaluations, I just want to let you know that we would like you to fill out an evaluation. Let me say before we get to that also that with mmlearn.org, you can go on and get programs about wandering and elopement, recognizing and reporting resident change of conditions, about dementia, MRSA, geriatric emergencies. I really encourage you with that. Ask the geriatrician, join us for this program. At the top, you're going to see this icon, survey. Please take it online or fax it into us. Let us know about these programs. We want to continue to bring them to you, but we have to get the feedback from you. Tell us if there's a program that we're not offering you'd like to see. contact us anytime that we can be of help at info@mmlearn.org, or go to our website and look at our catalog of courses at www.mmlearn.org. And I'll leave up our contact information. And let's see here. Exercise program. The program was great and very inclusive. I had a patient with frequent falls. I did an AccuCheck on him and found the patient had a very low blood sugar. Of course, I would recommend an MD order, but when he is notified, he may need to get an order for an AccuCheck. Thanks. And you know what? That's a wonderful point. If you go to Geriatric Emergencies, all of this is covered in regards to falls, the AccuChecks, the blood sugar levels, the hypotension. There are so many important things we need to know in caring for our residents. We just can't learn enough. It's 2:56. I'm going to give you a couple seconds to fill out your survey. I'd like for you to respond and let us know any thoughts about the program. We want this to be something that's going to help you, especially those of you who are out in the general community. Please don't think this is just about nursing facilities. This is for all of you. We're delighted. We're very excited that the residents at the Meadows got to join us today from their new media room. I think that's very exciting. I'm so happy to have so many members of our own organization here, but equally as happy to see all the different folks that I couldn't even list that have joined us today. Those that have asked for tapes, we'll make sure we get them to you. Just keep contacting us. Let us hear from you. So I'll let you fill out your evaluations. Thank you so much for joining us. We look forward to our next program, and we'll be glad to send you information about it. We're hoping it's going to be on geriatric pharmacy issues. So stay tuned, ask the geriatrician, and come back and join us. Thanks.